So in echocardiography conference, we have two sponsored program. Elegantly, Dr. Pandey has elucidated the sick patients. I am not going to touch upon the sick patient. They are apparently healthy patients, and the purpose of discussion is how not to make them sick in the future. This is the index patient who is 57 years and apparently healthy. The only risk factor is diabetes, and the blood pressure, if you see, is suboptimum. Now, this patient is not going to go to nephrologist or diabetologist at the beginning, maybe going more to physician. And what over a period of time the physician has understood that it is not the systemic blood pressure, it is the blood pressure inside the glomerulus also makes the future difference. And also we have able to understand one thing, it is not the creatinine or glomerular filtration rate what is important, but it is important to measure frequently urinary albumin creatinine ratio. There may be false positive elevation in acute urinary infection, otherwise a spot urine is a reliable one to pick up this patient who has apparently a normal GFR and leaky kidney. Why this is important to know? Because even if your GFR is preserved and you get a albumin urea, you fall into a high risk category. So probably we are not going to discuss those patients who have a overt proteinuria with a edema, then it becomes in the surface. But we have a segment of population who has moderate proteinuria, borderline GFR or normal GFR, or even GFR on the lower side, but the patient is asymptomatic. It is a report of creatinine which is showing a higher value, and this is the patient who needs to be picked up early. So the tagline of this lecture is diabetic hypertensive patient with proteinuria and preserved or mildly deranged renal function. Now, as we have understood that after the urinary albumin creatinine ratio has been ordered, it has been found that it's a little bit high on the screening, although the patient doesn't have any symptom. So how you are going to discuss this point with the patient? You need to discuss the point in this way that all diabetic patients ultimately fall into a intermediate risk category. There is no low risk profile patient with diabetes. They can have cardiac event, they can have cerebral event or microangiopathy. But the surrogate marker of having organ dysfunction directly correlated with the stage of CKD, and the stage of CKD you may not be able to remember or you may not need to remember all the time, but a borderline GFR and an increased UACR pushes the patient into a high risk zone. So apparently even the echocardiography is normal, but with these two parameters he is going to have a patient which ultimately what Dr. Pandey discussed about, the mortality is increasing and we don't have much thing to offer as of now. Even a low urinary albumin creatinine ratio may be detrimental in future for the patient. This is really the important thing which says or reminds us very commonly that we need to check more often this parameter than checking TSH, uric acid, all this thing. What happens is the mineraloreceptor overactivation is the key factor despite the patient being receiving AC inhibitor, SGLT2 inhibitor. And what the MR activation does is more inflammation and fibrosis into the liver, into the kidney and into the vasculature. We have already established molecule, that is ramipril, is lisinopril or statins, but they have not been shown to increase the renal outcome, although they decrease the proteinuria. SGLT2, yes, it is. Now, there is another molecule which we are going to discuss now, is the finrenone. So, what is finrenone? Finrenone is the key drug which prevents MR activation through antagonizing aldosterone and cortisol. Now, is anything more is available than finrenone at the present moment? Yes, we are actually using spironolactone for more than few decades, which usually came up with patient with gross ascites and chronic liver disease. And then we thought that this drug may be good for patient with heart failure with preserved ejection fraction. And also we found that this drug is good for patient with uncontrolled hypertension where hyperaldosteronism has been suspected strongly. Because of its side effects, as it penetrates the CNS, we thought that eplerenone may be a better choice. And in this today's scenario, we are using all these two in patient with this condition, and particularly heart failure with reduced ejection fraction. If we know very clearly their mechanism of action, that is not important. The more important is the pharmacokinetic therapies. So they have a little bit prolonged half-life, and which is a matter of concern that once the hyperkalemia develops, it takes time to disappear despite whatever you give, and then the patient needs to be in the hospital for a long time. So presumably, if you are giving a bulky non-steroidal finrenone, which has very high selectivity, no CNS penetration and a short half-life with a tissue distribution of kidney to other tissues, heart is 1:1, probably you are doing good for the kidney and the heart both. And with this thing in mind, a group of investigators has come up with more than 5,000 patients, and these are the Fidelio Figueroa group of studies. And rather than discussing the studies in detail, we come to what they have understood from this large trial, that patient with diabetes across all CKD severity treated with maximum doses of RAS inhibitor up to a tolerated level, and 40% of this patient has albuminic CKD with preserved kidney function. 99% patient have already been on a higher dose of ramipril, lisinopril or sartan, and the blood pressure was well controlled. There are some patients who actually don't have history of heart failure at all. So they are so-called silent sufferer. And when this patient has been given this treatment, what we found, the intention to treat group has a lower incidence of sudden cardiac death, which is very impressive. And all-cause mortality also is significantly reduced.